So warm welcome everyone to this session about the life science sector in the Netherlands. We're really happy that so many of you could join. My name is Michaela Anneling Swan and I work at SweCare Foundation. We're a semi-governmental organization working under the Ministry of Health and Social Affairs here in Sweden. With me, I have my colleague Anna in another room now. I'm not sure, Anna, would you just like to wave or say something? Yes. And we're doing this event together with medtech for Health and Henrik Minnedal. Henrik,
yes,
would
hello,
you like
everybody. Yes. A few words about medtech for Health. We're one of 17 national innovation or strategic innovation programs that is focusing on medtech products, medtech solutions. So.
Great. And something that we sort of gather information about together, SweCare and medtech for Health, was the interest from the life science companies to enter the Dutch market. And we will be having 3 different seminars throughout May, actually. So the next one will be May 17th. An invitation will be sent out shortly about that one. But we were happy to early get in contact with Ron de Graaff, who's a star and have put together this seminar. So I will start by giving Ron de Graaff the floor, and he will lead some of the other speakers throughout the event. But let me start by showing his slides.
Okay, thank you, Michaela. A short introduction. Today we will talk about the Dutch market, and we have discussed how we would do this, and we would do this today very practical with people from the market. So we are not giving statistics, how big Holland is and how many people does live here, etc. But we are talking about the real market and what's happening in the Netherlands. So I will give a short introduction to have an idea about how it works here. And after me, Frans van Andel will give some information about market access and innovations. And after Frans, Bert Verhagen, Dr. Bert Verhagen will join us and will talk something about how to do business in the Netherlands, especially with hospitals and other institutions. And Arend Roos will be the last speaker, and he will talk about doing business in the market from the elderly. I suggest that after each speaker you can ask questions, and then we try to give answers, so to have the answers available for you, so that the person who spoke can leave the meeting, because some of the people does have other things to do after or during this meeting. So I will have a start. And the first thing, and there's always the most important things, also for the Netherlands and also for other countries, no reimbursement, no market. And that will say that, especially in the Netherlands, we have a health insurance system where everybody is insured and everybody is enjoying healthcare products for free. And if healthcare products are not available for free, then people don't want them. So if your product or your service is not reimbursed in the Dutch market, it will be very difficult to obtain a market. So the main thing for you is to have a reimbursement or a decision about that your product or service is reimbursable. But it's the most important starting point for you. May I have the next slide, please? Michaela. Thank you. In the Netherlands, we have, of course, an insurance system. You can read it here, and it is said that everybody in the Netherlands is insured. We have insurance companies. You can choose your own insurance company, and every year you can choose again your insurance company. And there is a lot of competition between the insurance companies, and we know that each year about 1 million persons are changing of insurance company. So that is a lot of work to do, but it will say that it is a fierce competition in the Dutch market. And it is very important to understand that health insurance companies, at the end of the day, each company or each provider or each hospital has to do the business with insurance companies, because if an insurance company doesn't reimburse you, you have a problem. And in our system, the health insurance companies conclude the contracts with the providers. And if you want to do business in the Netherlands yourself, then finally you should have a contract with an insurance company, or you deliver your product to a hospital or institution, to a pharmacist or whatsoever. Those parties need to have a contract with insurance companies. So that is the daily practice in the Netherlands. So health insurance companies are very important. May I have the next slide? Here you see the number of insurance companies. There are not so many. And we always say we have the big four, Achmea, VGZ, CZ and Mensis. They have about 88% of the Dutch market. So those are the most important insurance companies to do the business. The most interesting ones are, of course, the smaller ones. They are more flexible and they are able to do more things than you should expect. But when you enter the Dutch market, for sure, you will meet one of them. May I have the next slide, please? In our system, the money is coming or is decided in certain acts. We have the Health Insurance Act, the Long-Term Care Act, and the Social Support Act. These are the most important acts deciding about what is available, what can be done, where's the money coming from, how is the money flow, etc. These are the things that you should have a certain understanding, because when you're in the Netherlands, you will meet these acts. Because the party you are working with, they have to do it with these acts. And the next slide shows where the basic package in the Health Insurance Act is mentioned, that medical care, time spent in hospital, etc., is insured by this act. So if you want to have medication, it is in the basic insurance. If you want to have maternity care, it is in the basic insurance. And this law is also deciding about who is able to deliver, what are the conditions, what does an insurance company have to do, and what also has a care provider to do. It's all decided in this law, and based on this law, the money flow is coming. So may I have the next slide? The Long-Term Care Act, that's for the long-term care, of course, institutions. It's a complete different system compared with the Health Insurance Act. This is more a budget finance system. And it's also interesting to know how that works. For this, we do not have the insurance companies, but we have the so-called health officers who are responsible for the negotiations. A complete different system. But if you're working in this world, you have to know how it works. And the law, the WLZ, Long-Term Care Act, is indeed, the one you need to know. And the next one, please. The Social Support Act. This is the act which is regarding the municipalities. The municipalities in the Netherlands, we have about 280 municipalities today. They are responsible for support of citizens. So it might be that your product or your service is fitting in the scope of the municipalities. That's another flow of money. In this market, we have generally tenders because the municipalities do have to tender. And health insurance companies or the health officers do not need to tender. They can tender, but they do not need to tender. But the municipalities do need to tender. It's European law. And there's also a complete different world with different actions and different people than in the healthcare acts, etc. So these three acts are deciding where the money is coming from and what you should do or could do, have to do. The next slide. This is also interesting to know that if your product is just an investment product, you do your business with the institution or the practice or the hospital who is willing to buy. They decide in their own budget if they buy or if they don't buy. You don't need a certain code, you don't need a certain decision. It is just a decision of the institution. But if your product is to be used by an individual person, then it might be that it is insured, and then you're in the system that you need to have a code, that there need to be an invoice, that there need to be a positive decision, it is reimbursable, etc. So that's more difficult. So if your product or service is investment, it's more easy. It's one-to-one business to the institution, but is it for an individual patient, then it is more difficult, because then it has to fit in the system, more in the system, and other persons are deciding about reimbursement and the buying process. Yeah, please, next slide. This is for now my last slide. It gives you a little bit insights of the market. Depending, of course, what your product and intended use is, it might be the hospital market. We have 71 hospitals with a lot of locations, 116. We have a lot of nursing homes, 667, quite a lot. We have a lot of home care institutions, and it looks like a lot, but there are big ones, and there are also very small ones existing of 1 or 2 persons, but a lot of institutions. Rehab institutions, 140. GPs, 12,000 GPs, 12,000 plus. GPs are very important in the Dutch market, because you always need to have a referral from a GP to be able to have your medicines or your medical devices outpatient market. Or when you want to go to an hospital, you always need to go first to the GP, and then you're able to go further in the system. Dental care, a lot of dentists, paramedical care. We have a lot of physiotherapists, almost 30,000. Mental health care, 2,000 people working in that world. Pharmaceutical care, 2,000 pharmacies, with a lot of pharmacists, of course. And yeah, our population today is 17.4 million, and I think it might be 17.5 million because of a lot of inflow of foreign people, 76.6 million maybe, 65 plus age, but Arend Roos will tell you more about that, the elderly market. Life expectancy in the Netherlands, 80.5, 81.5, health expenditure of our GDP, 10.2. So we spend a lot of money in the Dutch healthcare, and of course also in Sweden you spend a lot of money in the Nordic countries, but in the Netherlands compared with the south of Europe we spend a lot of money. But this is in short a little bit about the Dutch market, where you do have to understand that your product or service should be reimbursed, otherwise it is not used. If it is a product for an individual person, is the product to be used in an institution, in a practice or whatsoever, and they have the budget, they can buy themselves, they can compare the brands, they can compare the prices and whatsoever. If you want to deliver yourself in the Dutch market to the end users, to the patients, you probably need to have, for sure, you need to have a contract with an insurance company. If you're using distributors, then your distributor needs to have a contract with the insurance companies. And bear in mind, contracting insurance companies is quite a job, because they know the market, they know the products, and they know the prices. They want the lowest price, of course, and the highest service, like everywhere. And they are tough in negotiations. And that's why I'm happy that we have on board today Arend Roos and Bert Verhagen, who are from the daily practice and are able to tell you a little bit more about how you negotiate, what can you expect, what is done and what's not done, so that you have a good understanding about the Dutch market before you enter. In the next meeting, the next seminar or webinar, we try to talk more about the market access, but that will be for the next webinar, so that you also have an understanding what you should do, shouldn't do, and what you could do to have your product reimbursed in the system. We are not talking about that, but Frans, the next speaker, will talk about reimbursement for innovations and what are the possibilities. Frans, it was 15 minutes, about 15 minutes for you. Before I give you the mic to you, I would like to ask everybody, do you have questions?
We do have questions, and may I suggest that Masoud Jadidi, if you could actually ask your question yourself, you'll get the better answer.
Yeah, Thank you very much. Thanks a lot. Thank you, Ron. Very nice presentation and very good insight from the market. Actually, I have two questions. You emphasized very much about the insurance company. My question is, do we need to approach the insurance company directly before we go to the healthcare providers, or is the combination activities we should do in parallel?
I can make you very happy that you don't need to contact insurance companies before you meet a distributor. I make it stronger. They don't really want to see you. They only want to meet people like distributors with whom they contract. So manufacturers or people who are not giving direct deliveries to the patients are not able to speak with insurance companies. They don't see you. So that's also the problem for a lot of manufacturers, that they do not know what is the policy of an insurance company. So they are dependent of the distributor's know-how and what the distributor has agreed with the insurance company. And especially when your product is not a unique one, but you are in a competition with other products and your distributor does have other products, then it will be very difficult for you to have an understanding what he can do or can't do regarding the insurance company. But okay, that's the daily practice that you will find out. But generally speaking, you are not able to speak with insurance companies unless you are a distributor who is in need of a contract.
Thank you. You answered the second question as well at the same time. Thank you.
Okay. Other questions?
Yes, Fredrik Herrenstam, would you like to ask yours?
Yes, thank you for the presentation. Great to be part of this seminar. A lot of good information so far, so look forward to hearing the rest. I have a quite specific question, so feel free if this is something you're going to cover later on, but I'm wondering whether cancer screening tools or cancer screening programs are covered by the same Health Insurance Act and reimbursed through insurance companies, or if there's a different structure for this.
Screening of cancer is something done in a national program, depending, of course, on which kind of cancer. We have the so-called breast cancer screening that's done for ladies in a certain age, and we have, I don't know the English word, darmkanker. Maybe somebody knows the word darmkanker screening is also regularly done every 2 years. So
colon cancer.
Yeah, colon cancer. There are a lot of screening programs, but if you're coming with a new screening tool, you have to bear in mind, we have mentioned that we have a law on cancer screening. It's not a law on cancer screening, but we have a general law that prohibits screening for cancer without permission of the government. So the government wants to give a permission that you're able to do a certain form of screening. So it is not able to sell screening products just in the market for cancer, because the government is afraid that something is going wrong and that you're running to the doctor and that you're going in the hospital, and at the end of the day it was a wrong test. So they want to be sure that testing and screening is in an appropriate way and that no mistakes are made. So that's why you need a permission to deliver, to sell this kind of products.
Okay, thank you.
Do we have any more questions?
Yes. Other questions? In addition to the last question, it might be that screening of these kind of products can be reimbursed by insurance companies, or it could be reimbursed in the national program, so that if you have a certain good screening product, then it might be reimbursed in the national program. It's also depending what are you delivering, which kind of cancer, etc., etc.
Yeah, and to be more specific, are you focusing on the next generation sequencing, etc., or other type of screening projects or tools?
Yes, it's a liquid biopsy platform.
Yeah, that's very tough.
Yeah, it's very tough. But the first step in the discussion would be in the Netherlands that you contact organizations of involved doctors to see what they are thinking about it, etc. So we can think about a certain road to reimbursement, a pathway to reimbursement. So there are possibilities.
That's great to hear. Positive. There's an opening, but it's a long journey for sure. But thank you for the answer.
Okay. Mikael, no more questions for me for the moment.
No, so I'll just switch presentation then.
Yes, to France.
Welcome, France. Yes.
France.
Hello, all of you. So let me briefly introduce myself. I'm Frans van Andel. I'm a public health specialist and a health economist. I've worked for more than 30 years in market access of pharmaceuticals and medical technologies. Internationally, I was medical advisor for the World Health Organization. I worked for the European Union, and the last 15 years I've been working with Ron in a company in the Netherlands. So the brief I was given for my presentation was to give you a little bit of flavor in terms of how innovations in the medtech sector can be supported in the Netherlands. What sort of programs do we have? And what I want to do is I'd like to focus on an area which Ron described in his presentation as individual products, so products for individuals rather than investment products. And the approach I'm presenting here applies to individual products. So next slide, please. So as a starting point, just very briefly and broadly, if you want to get a product in the reimbursement in the Netherlands, you have to fulfill two conditions. One of which is that the Dutch Healthcare Institute has to evaluate the proof of clinical effectiveness and use in medical practice. In other words, the clinical effects of a technology and to what extent Dutch practitioners, specialists or whatever are using the technology. And secondly, if you have a positive evaluation by the Dutch Healthcare Institute, you still need a payment code, which has to be issued by the Dutch Healthcare Authority, or NZA in Dutch. So next one. So if you want to circumvent these two conditions of clinical effectiveness, or STWP in Dutch, and issuing of a code, then you may want to develop a project in the field of innovation stimulation. Innovation stimulation for the medtech sector very much depends on whether you want to do this in the primary or the secondary care sector. So I have given some examples, which I will talk about in a minute, for the primary care sector as well as the secondary care sector. For the primary care sector, for instance, so-called S3 financing, M&I financing, or the BRI financing. And the secondary care, the optional benefit financing, and the same instrument which also applies to primary care is the BRI financing. So next one. So as you will see, many of these schemes which I'm presenting have some commonalities. So a lot of these schemes are about improving efficiency, improving quality. They're also about the right care at the right place. And it really depends on who's applying at what level of care, which scheme applies. And it also depends on the context of the application. So for instance, S3 financing is innovation financing for general practitioners. And an example of this would be to set up schemes in dermatology, eye care, or cardiology, or other disciplines focusing on what we call 1.5 line care. So this is not specialist care, It's not GP care, but it's a practice where the GP takes over certain services from the specialist and sets up what we call 1.5 care. And medical technology is extremely useful to realize 1.5 care. An example we're working on at the moment, for instance, is a new test for an allergy, which used to take place in the hospital, but can now be done in primary care. And this would mean a complete shift of care from the hospital to the primary care sector, and would fit extremely well in this concept of right care at the right place. So a second scheme at the GP level is the M&I financing. Again, M&I stands for Management and Innovation. The important issue is a shift of care from secondary care to first-line care. But this scheme is more focusing on management of costs rather than on technology innovation alone. And there are, in fact, a lot of examples of M&I financing schemes focusing on new systems of ECG, tele-echo, teledermatology, and a lot of other systems. And then the third example I have is BRI financing. BRI stands for Financing of Innovation Policy Rule. And the focus of this type of instrument is on innovative care, but at a better price and a better quality. Again, this substitution or second to first line is important, as well as improvement of quality of care. With lots of examples of successful BRI projects where we have been involved in. And medical technology usually is quite an important component of these type of projects as well. So options for new technology, definitely. Yeah, next one. So secondary care, the optional benefit financing scheme was set up to create options for financing for benefits or medical technology or other medical procedures for which no reimbursement code is currently available. The problem when you have a new system which you want to introduce in the Netherlands in secondary care is that you need a payment code, and if there is no payment code, then quite often you don't have any options for financing unless you want to use an existing code, or you want to go through this long pathway of getting clinical effectiveness evaluated as well as applying for a code. And to really provide a solution, this optional benefit scheme was set up. It's rather successful. It's now been in operation for 2 years, focusing on specialist care with free tariffs which are negotiable. Again, this concept of right care at the right place. And the example I gave earlier about this 1.5 care, in fact, also applies to this optional benefit scheme, financing scheme. But here the entry is the secondary care, whereas in the previous example, it was first-line care. And the example would then again be this innovation of allergology treatment by setting up sort of in-between services focusing on allergology care. Then the innovation policy rule also applies to specialist care, but I already discussed that in relation to primary care. So next one, please. Now, another scheme I briefly want to touch upon is the grant funding scheme of promising care. And this is not related to primary care or secondary care as entry point. This is any sort of healthcare institution provider can apply for grant funding. This is a new fund which was set up about 3 years ago for technology, medical technology, which has insufficient clinical evidence at present, and for that reason cannot apply for clinical effectiveness evaluation or application of a code. And these are for technologies of companies who have insufficient funding themselves to pay for this whole strain of clinical evidence.
Ja, bara väldigt kort. Jag skickade dig där den uppdaterade grafen.
This is a language I don't understand. Hello? Can I continue?
Go ahead.
So this promising care scheme, the idea is to provide funding for clinical research. However, we've been involved in many proposals. It's a long haul approach, as we call it, because you really need very thorough proposals with sound clinical trial planning and methodology. But the funding is quite generous. It's on average 3 million euros for projects with a duration up to 5 years. So next one. Next slide, please. Now, it's short words about e-health, because I was asked to also spend a minute on that. The rules in the Netherlands are that for e-health systems, the requirements are similar as for any other medtech. In other words, you need to proof of clinical effectiveness and a reimbursement code. However, e-health products can quite often use existing reimbursement codes, and clinical effectiveness is assumed if technology fits the following statement: composition and clinical effectiveness of care is unchanged in comparison to existing care for which code was already issued. The examples are many, for instance, tele-monitoring for dermatology, or consultations by specialists in many different areas. So as long as the output of the e-health system is similar to what would be done physically in terms of a consultation, for instance, as long as that is the case, the system is relatively easy on saying that the composition and clinical effectiveness of care is unchanged. And in addition to the many schemes I just outlined, we have in the e-health sector quite a few schemes which only apply to that sector alone. But it very much depends on the type of healthcare you provide, which grant scheme is available: primary care, secondary care, preventive care, etc., etc. So next slide. So that brings me to the final slide. Our conclusion is that the environment towards stimulation of innovative medtech in the Netherlands is actually quite supportive. Ron, in his briefing to me, said that I should not give any numbers or data on the market, so I won't do that. But just to give you one piece of information, the medtech innovation sector, in terms of funding and in terms of number of firms and number of people employed per million people, is among the top 3 in Europe. As I outlined, a range of stimulation options exist depending on type of product and which sector of the healthcare this affects. What we usually suggest is that before we start analyzing what options there are, it makes sense to do a scoping study, first of all, to look at what sort of reimbursement options would be available or could be developed for a technology, and what is the state of the clinical data for a technology, and to what extent can we make use of these innovation schemes I just outlined. And then finally, for Swedish innovative medtech companies, the options are in principle the same as for Dutch companies. But at the end of the day, it would then help if these Swedish companies would have at least a Dutch affiliate, or in some way, in one way or another, have some elements which could be called Dutch rather than only Swedish. So we're happy to support you in whatever efforts you have in the Dutch markets to see if either the reimbursement can be developed or a scheme can be set up on which basis innovation can be stimulated. Thank you.
Thank you very much. Do we have any questions?
Well, that's easy.
It's a lot of information to take in.
Well, as Ron was saying, we will dwell on many of these issues on the 17th of May. But the idea was to just give you a flare of options we have, and see if whatever I was delineating may apply to your situation in Sweden.
That sounds great. Should we move on then with Bert Verhage? Do you have your own slides to share?
No, I don't have slides. I think it's more a question and answer session from my side. I'm from background doctor in internal medicine and since recently insurance physician. It's a specialty, insurance medicine in the Netherlands, and very hard to understand. I think it's interesting to know what specific questions you have, or what kind of products you have, or projects. Because the way of selling it or tendering it is completely different for a pharmaceutical product or for a medtech product. I think to outline more or less our activities, as soon as there is a reimbursement code and there is a registration for the product and you can start selling, we are more or less there to think about how to sell it. And also one step earlier, if you have a development in mind and you think about Europe and you are thinking about, shall we include the Netherlands, yes or no, in the project? At that moment of time, we are there too to discuss with insurers or with hospitals or key opinion leaders or who else. Is there an interest in this project? Or, for instance, is there a strong competitor with a big footprint in the Netherlands? Are there other hurdles? Because I think it's interesting from your side to know, what are your questions? And we are eventually, from the key opinion leader management for creating the markets, we can eventually deliver the product at the patient's door or at the pharmacy or at the hospital, and that's a whole chain of activities we have. But the most important thing is, as soon as it's reimbursed, who is the client and who is willing to pay for the product? There's other specific questions.
I have a question.
Go ahead, Masoud.
This is Masoud Jadidi. I'm a vice president for Imaging Care. Imaging Care is a digital solution for remote patient monitoring at home or primary care or secondary care or care home. So you mentioned in the beginning that you are helping Swedish company, if I don't misunderstand. What kind of the help you are talking about, or how you can help?
Now, I don't know if your product is related to cardiac surveillance and heart rhythm, etc.
Yes, we are using for heart failure patient.
Yeah.
So we have a study result from the study in Sweden, one region, that we reduce the hospital admission by 50% for heart failure patient.
Yeah. What our first approach is, of course, your competitors, huh?
Yes, indeed.
You don't have to look in your competitors.
No.
You have
we
to
know them very well, and they know us very well as well.
Then we have to know from you, are they present in the Netherlands? Do they have an office? Do they have, etc., etc., etc.? And then what we generally do is looking in PubMed, who is the leading professor, who is the leading key opinion leader in the Netherlands, who is in charge of your specific problem or project, so that you have the top expert on board. Of course, he will be maybe on board of the competition too, but due to the fact I can write somebody like that as a doctor, I write in general a general question about his last article and ask him some questions, and we start a discussion, and then eventually I say, okay, I have some commercial contacts. Are you interested speaking with them, etc., etc.? And then it's more or less a decision point. If somebody says, no, we are absolutely not interested because we are already settled or we have already a cooperationship, then it becomes, in a tiny country, very hard to be the second one, because the hospitals are buying more or less in groups and in clusters. If we have one person who is interested in your products and in your services, we ask them, you are professor, this by definition, you are not seeing that much patients. Do you have a good colleague who is seeing patients in large volumes or responsible for a certain department in cardiology? A person you trust, from your study, and we can start a sort of collaborationship, a professor and somebody in the periphery. Then we have a very small round table. Then we discuss more or less the next steps. And then we have to see who has the contacts, because this is a project which is not directly funded by an insurance company. Who has the contacts, the cardiologist, the professor, we all together, to approach, to present the project, etc. That we have a project which is a pull product, is that the professor and that the hospitals are already in, and that we don't have to push and to promote, because pushing and promoting in the Netherlands is not the way to sell something. Then we start in general with a small observational study or a free trial for a couple of patients. We publish the results, and then, depending on the size of the company and the money you have to spend, you can expand, and then eventually you will find a source who will fund it. The most important thing is that you are not funded by a project, because a project has a beginning and has an end. This it must be somewhere structurally embedded in the reimbursement system, and maybe creating a specific reimbursement code with our colleagues. So that's more or less an answer to your question.
Thank you. Can I follow up with you in the separate meetings?
Yes, no problem.
Okay,
No problem.
Thank you. Thanks a lot. I have some more question, but it's more detailed. It's not in this forum. Thank you.
Yeah, a general message is the Dutch market is not a push market, I think. Yeah. But in Sweden, you know it, all the sales reps are more or less gone. Huh?
Yeah, but this is what we need, the pilot study and the studies, because our solution is very based on clinical evidence. Mm-hmm. So if we don't have a clinical evidence, so it's no idea to go to sell anything, because this is very much in align with what is the outcome of the care. It's not the number of the how much you are selling, which hospital is the most important. And this is what we have in Sweden. This is the key, that we have a statistically clinical evidence, the outcome of the care.
That's very interesting. Early warning system for patients who are more or less decompensating on Friday evening, spending the weekend in the hospital, and on Monday discharged.
Spot on. Exactly. And we have evidence on that. How much the government is saving, how happy the patient can be, and the reducing the number of the hospital admission.
Yeah.
Very good.
Okay. Other questions?
Do we have your email address and in the invitation? I don't know. I'm not sure. If
we can gather. Yeah, we gather all the information and we'll send it out to you after.
Thank you.
Sure. Do we have any more questions?
No. Then I can comment a little bit on the pharmaceutical market in the Netherlands. I think if you have specialty drugs, you have a very good position in the Netherlands. If you have evidence, we have rather good prices, rather structured way of getting eventually a reimbursement. It's a market which is for orphan drug companies very attractive, also for the chemotherapy in new variants, etc. The generic and it's a very conservative market. If you're in, it's not so simple to get out. For the generics, it's a completely different world. It's more or less you have business for a couple of weeks, huge businesses, and they are gone in a couple of months, and the competitor is taking everything over because they gave a better price or they gave a better conditions on shelf life or other conditions. And the way the insurance companies are deciding is very hard to understand. There are no guidelines, there are no real directives. The way you act with the healthcare insurer is more or less the same as you are acting with a wholesaler. It's typically trading. We are offering you this. We give you a discount like that. No, we are not interested. Can you give a higher discount? Yes. And for how many years, etc., etc. And they are all more or less face-to-face meetings. They are not organized in a European tender system. There were quite some lawsuits from big pharmaceutical companies that the Dutch healthcare insurers were acting like that. But eventually they said, no, it's not a tender. The partners we are closing contracts with are preferred suppliers. Thus, it's very important if you have a product in mind to start in an early stage with the healthcare insurers, a discussion, maybe even before you start registration or reimbursement. The question, if we are on the market, if we are reimbursed, are you interested in this product with this percentage of discount or this USP? Because if the insurance company is not willing to close a deal with you in the end, there is no alternative route or a bypass. And then if you have eventually a deal with an insurance company, you think, okay, we are there. Then you are still not there because we have pretty influential wholesalers with an enormous amount of parallel trade. Dus if you bring your Swedish products with a contract with the healthcare insurer to the Netherlands, and you think, okay, it's an attractive volume, the wholesaler sees almost immediately that's an attractive volume, and they bring the stuff in from, let's say, from Italy or something like that. Dus, and the wholesaler block you. If you start a discussion with the wholesaler, they say, oh, yeah, it's difficult, or dus it's from the beginning on important to have a very good relationship with the wholesaler too, because they can frustrate everything what the healthcare insurer agreed with you. Dus yeah, that's more or less the pharmaceutical business. The medtech business was addressed, and yeah, the biologicals are also very interesting because there is still, yeah, a very attractive margin, a very attractive system. That what Ron mentioned. Almost all the products are available in the Netherlands, totally reimbursed. Because if the product exists, the product is in the end reimbursed, prescribed, and used. Yeah, that's more or less in a nutshell the Dutch market. And I don't know if there are more questions from your side.
Do we have any more questions? If not, thank you very much, Bert, and we'll move on to Arend Roos. And thank you very much. I will share your slides.
Sorry, Michaela, are you sharing my slides now?
I said so. I'm trying. Sorry, it's just.
Yeah. Sorry, but I made a slight amendment this morning, so that's why I asked you to let me present my own slides.
Perfect. Go ahead then.
Yeah. Are the slides visible to you?
Yes.
Okay, good. I'm representing Rose Health. It's my company, and we are experienced in health and innovations. We have our own experiments and projects in which we build solutions, and apart from that, we operate also in the consulting and business development field. And recently, we had also successful experience with helping a company from the Nordics into the Dutch market. Later, I'll elaborate more on that business case. And as Ron has mentioned, my presentation will mainly be about the market for elderly care. That's where most of our work is currently. When it comes to the demographics, I think that I'm not telling many new things to you if I say that we are facing a big challenge. The number of older citizens is growing. It's innovations and many innovations in the field of medical innovations and also pharmaceuticals lead to a longer life. And that brings, oh, sorry, that was not what it was supposed to be. Brings us so that people live longer with chronic diseases. So there is a growing number of older citizens. at the same time, there is a lower number of people in the labor force to deliver that care. And already at this time, we face some challenges. Of course, we don't take into account that, for example, by migration, a part of this challenge will be solved. But at this moment, our government foresees that where now on average 1 out of 7 people is working in healthcare. If nothing changes, that will be 1 out of 4 in 2040. Economically, a very high burden, but also the people are not there. And that's why there's a growing awareness in Dutch elderly care at the moment that also innovations, technology should bring a contribution to solving this issue. Yeah, when it comes to innovation, well, just remember the first slide that Ron told us. You can have nice technology, and you can be aware that social innovation is important to let the technology work, but we're nowhere if we're not able to find a way to have our solution reimbursed in the system and let the ball roll. I will try to explain a little how the reimbursement scheme is organized when it comes to elderly care, based on something that might be familiar to you. And that is the cycle of our lives. We are first vital people. There will be a moment that we age, and there will be a life dependence. Then we come in the stage of receiving home care, and that is in Sweden as it is in the Netherlands. And home care here, that is the increasing immobility leading to ADL support. And in the end, there is this phase in which people are taken into nursing homes. They are receiving residential care, or sometimes, and a growing number of people, that's the case, they have the assessment for being taken into a nursing home, but they choose to manage their own care, and they are looked after by home care organizations or by private nurses at home with the budget from this long-term care. These stages are all funded, or the care in these stages are funded in different ways. You've heard a lot about the insurance providers. They are funding hospital care, GP care in the vital stages of our lives. The light dependent stage, the stage in which people are taken into daycare facilities, in which people receive domestic help, for example, or personal support at home, or assistive devices like a wheelchair, a cane, or a walker, such things. Well, canes you need to pay yourselves, but these medical device or assistive devices, that's paid by the municipalities with the Social Support Act. Then home care is delivered by home care providers, but it's funded again by the private insurance providers. Remember the big 4 on Ron's list. And then the long-term care, nursing home care, or the care for disabled people is paid by these health offices under the Long-Term Care Act, the WLZ. In elderly care, the stage of home care, there are on an annual basis around 500,000 Dutch people receiving home care. The number was increasing, but due to changes in regulations, it's more or less the same at the moment. People who are receiving care under the Long-Term Care Act, that number is growing, and it was last year around 170,000 people in nursing homes or having an assessment for long-term care and receiving care at home. This separation between the different health acts and also the different organizations reimbursing that care, that brings difficulties, of course. Many innovations, in particular preventive innovations, are focusing at a certain point in care or a certain point in the lives of people, but the one who is responsible at that time is not always the one that takes the financial benefit later. And this way of organizing healthcare, that makes it sometimes difficult to have a good funding for your innovation, in particular when it comes to early detection or prevention. There are more and more funds based on the awareness that there needs to be done something, which try to stimulate new initiatives and to work both on stimulating innovations, technology, and also the social side of it, both for the citizens and for the care staff. One of the biggest programs that we had last years in the Netherlands was the Dignity and Pride program. It was a program in elderly care which with these two terms defines quite clearly the awareness that it's both about the quality of the care, the dignity of the older person, as well as the professional approach of the care worker and the pressure, the growing pressure that's on these people. And from this program, several programs are initiated, focusing on both quality of living and shortage of labor. And since 2017, more and more money has been allocated for several initiatives, in particular in the long-term care, around 2 billion euros, which found slowly but at a steady pace their way into the world of nursing homes. And a big program that also now several technology companies, e-health companies tap into is the so-called Anders Verken program. Literally, that means working differently. Again, stressing the need for innovation, but also that innovation cannot be there if it's not taken up by the care staff. It, as I said, it has to focus on long-term care and then long-term care as connected to the nursing homes. But at the moment, we see that the scope is widening and that more and more home care organizations who are in an earlier stage in active in elderly care are taking part in these programs and are taking up these initiatives. And why am I saying this? Because in elderly care, we see that most companies that have successful products and want to bring these products to the market, most of the times only can be successful if they team up with innovative nursing homes. If they are able to team up with a home care provider that sees the value of that product and that is able to let it work for their staff and their clients. And the funds which are available from these transition funds, but also the right care at the right place, which just was mentioned by Frans. These programs are focusing on care organizations, but as technology companies, you can be part of it. If you're part of a consortium or as a subcontractor in such a project, you can benefit it, and you can also then use the
space created by these programs to evaluate your product and also to leverage it and bring it to the attention of the wider Dutch audience. As said, we recently have an experience with a company from Denmark. The company with the name DigiRehab. They provide an e-health solution which turns a home care staff into the home care worker into a personal trainer for elderly. So by assisting them to give targeted rehabilitation. And they were, like you, facing the challenge, how can we internationalize this? And what's quite nice to say in this meeting is that I was brought into touch with them by Ron, and they needed to find a way to test the product in other markets. And well, early last year, I started working on the case for the Netherlands for this solution. The approach was not known in the Netherlands, and there was no reimbursement for this yet, even while this was a solution that just could be procured by home care staff. But the challenge was that if home care staff is using this solution, they save money, but then if they spend less hours on home care, the insurance provider is paying them less money. So the home care provider is the customer of this company, but the one taking benefit of it is the insurance company. So we need to make that case. We started, as I just did on that slide, with just the awareness that older citizens in Denmark are similar as the older citizens in the Netherlands. So something that works there. It's quite plausible to think that it will work in the Netherlands as well. Then I started looking for home care providers who shared this idea and were willing to test. We found one, and we built on a strong partnership between both organizations. And in the meantime, 2 other home care organizations joined. And with them, as the other presenters already told, with them, we went to the insurance providers. So we did not go ourselves to the insurance providers, but we asked the home care providers to present the business case to the insurance providers and to ask to make that a part of the contract for the next year. This approach can take more time than when you set up an innovation project. And with an innovation project, you have the opportunity to have money for your products. You have the opportunity to have some funds for project management, etc. But the challenge is still then that after the project, is there structural funding for the solution or not? And because that's often not the case, we decided immediately to go to the commissioning service of the insurance companies, and or at least to ask the home care providers to present the case. Well, and then we teamed up in communication, and as soon as the insurance providers, and in this case CZ and VGZ, both part of the Big Four, as soon as they said, okay, we'll give it a go and we'll write this in the contract for next year, we were honest that also or at least the home care providers deserved also the credits for this. And based on that, there was a very strong bond of trust between the partners involved, and that helped this company also to reach the point that they incorporated a Dutch subsidiary. So that's my presentation for now. It's as Ron said, it's quite practical, but that's also the way in which we work. We try to make it practical, to let it work in practice, and from there to see how can we fund it? Main takeaway, there is enough money, but it's not always easy to get it. But if you have the right people with the confidence and faith in your solution, then there's always a way to get it from the ground. Thank you.
Thank you very much. Do we have any questions?
I have one general question. This is Masood from Imaging Care. Regarding elderly care, is it mostly private elderly care or the public or combination?
Formally it is private. All organizations are private organizations, but they have to be not-for-profit organizations. There are also some organizations that are more or less privately organized or in private companies. And it's restricted strictly, so both in the quality and also the financial audits. But I think the other presenters know more about this way in which it's organized. We see that this way of privatizing healthcare that started in 2006 in the Netherlands has led to a quite broad offer. You see in a region many elderly care organizations say that because health is a public thing, that they are not competing with each other, but in fact they are, and they are having a different offer, trying to find niches in the market for elderly.
And does it mean that to do the pilot project is easier and they don't need to have a tendering? Can be easier to have a pilot?
Yeah.
Okay.
That can absolutely be easier. Yes.
All right.
Then in this case, I'm going to follow up with you to discuss. I will send the email.
Okay. Thanks.
Okay.
And Anna, you had a question?
Yes, I was wondering, perhaps in general, but maybe specifically for elderly care, are there any initiatives to support healthcare or long-term care staff to use new technologies? Because that's often a problem that they're not so used to doing that. So I just wonder if there's in general.
Yeah, there are several initiatives. So there are funds that's the low-hanging fruit. To have digging coaches in every organization. So that's one thing. But I see also that where about 5 to 7 years ago, there were only funds to develop and test technological innovations. At the scope of these programs has changed and is focusing more on implementation, and that's both from the domain of economic development and innovation, where it's said that implementation and the social innovation side of it is very important, but also the programs from the Ministry of Health. I just mentioned the Anders Verken program, the Working Differently program, and that is in that program. It is very clear that the role of the care professional is crucial to let the innovation work or not. So they are not only open to solutions that are still in the last phases of development, but also to solutions which are on the market already. And the budgets from that fund are also to help organizations to take it up and to let it work, to educate the professionals and to help them to work with it. And it's sometimes that we use these funds also to to set up innovation projects for companies who are willing to train staff. In a broader sense, I see that several regions in the Netherlands have innovation budgets to tackle the problem of on the labor market in general. What we are saying about the labor market in healthcare, we see that also in leisure, for example, or in the process industry. There's a shortage of labor anywhere, and we see that several regions have budgets to tackle labor force issues. And sometimes we can use these funds also to help health tech companies to set up an evaluation of their product together with the healthcare provider.
Okay, thank you. That sounds good. It's important that, as you said, it's used actually.
Do we have any more questions? If not, then I will hand over the word to Ron.
Thank you. Thank you, speakers, for all your input. It's very important to see what is the daily practice in the Netherlands, because that's something that companies could use when they are thinking about coming to the Netherlands. I would like to add a few things. We are facing a change in our healthcare system. We have seen before the COVID pandemic, there was a report of the Dutch government or a governmental organization which wrote the report Choices 2020. It was written in 2020, and due to the fact that there were a lot of costs, a lack of people working in healthcare, and how are we going to do that in the future? This report is about a 600-pager, and I think that a few people read it because it was in the COVID pandemic, so we had other things to do. But in this report, there are a few important things to understand and to see. One of them is that in our Dutch healthcare system, we are reimbursing a lot of products and services which are not proven, which are accepted in our system a long time ago, that are still reimbursed. But the question can be posed, is this healthcare really healthcare? Is this doing what we expect that it should do? And we started already, the Dutch government started already a project with re-evaluating all these processes. And if this process is not okay, it is a lack of evidence, but we are still doing it, it's a lack of evidence, then we are not going to reimburse it anymore. So that will be a tough discussion. It's also suggested to skip a lot of reimbursement of medical devices in the outpatient market, thinking that people can pay it for themselves. This is already an old discussion. It's already 10 years ago. Why should we as a government pay for diapers for elderly people? Can't people pay them for themselves? But it's a political issue and a discussion. But the government is thinking about what will be the healthcare in the future, and also regarding to the presentation of Arend, we see that a lot of things are going to change, and that we are going to invest in new ways of thinking about healthcare. Another issue is also, and that's also interesting for companies who want to start on the Dutch market, one of the failures in the market is that implementation of a new product or a new service is not done in the right way. We see often that something is introduced that will give savings. It should be worthwhile to introduce it because it's better, it's cheaper, etc. But in the daily practice, we see often that the people doesn't use it. They still stick to the old ways, and they are also always doing it in the old-fashioned way, and the new technology or the new innovation is not used. It's bought by the hospital, but it is not used. So that's also a big problem, that often the training or the education to the people who are going to work with it is not done or is not accepted, because we have learned to do it in this way, this is something new and we don't want it, but we need to do it, but we, etc. There's also one of the problems that if you want to introduce your product in the market, then you also need to think about the implementation project. And it might be that you also should offer training to use it, and that you also should monitor the use in the daily practice. This has nothing to do with IDR and MVD, because then you have to do a lot of PMS things, post-marketing surveillance, but this has to do that if you introduce, that you have to take care that it is done in a proper way in the institution or whatsoever. It's often forgotten, and it might be a plus for you if you are able to bring that also in the project. Furthermore, as discussed, we have discussed the situation of the insurance companies. Now, insurance companies, are more or less the party who decides if your product is reimbursed or not. It might be in the system that you have a code so that you're able to invoice it. It might be that you have a positive decision, yes, you are reimbursable, but at the end of the day, it is the insurance company who decides, yes, we are going to reimburse, because we know and we have seen that insurance companies can make certain providers preferent. We have also seen that some hospitals were not contracted by insurance companies because they were too expensive. We also see that insurance companies want to influence the hospitals by saying, yes, you need to do so many operations per year, otherwise I don't contract you. I want you to be a better hospital than in the past. I want you that you are going to cooperate with another hospital, that you join forces, etc. Based on the system of contracting from insurance companies towards the hospitals, we often see that today they make a certain budget deal and they say, okay, and when the budget is over, you still have to deliver services. Also in those contracts, insurance companies are quite strong. They said, even if your budget is gone in September, you have to deliver the healthcare until December and you're not paid for. So the position of health insurance companies is quite strong. If you look to the medtech market, to the outpatient medical technology, medical devices, insurance companies contract with medical supply shops on a certain assortment, or they give a certain budget, and then it's a choice to the distributor to make the right choice, but they have to deliver a certain quality. So be aware that insurance companies, they look a little bit silly, they look a little bit old-fashioned, but they are quite strong. And at the end of the day, you need them, because if you don't have a contract for your products, or your distributor doesn't have a contract for your products, you're out of business. And as Bert mentioned very well, yes, try to have a contact with an insurance company early phase. In the pharmaceutical world, in the pharmaceutical department of an insurance company, it might be possible, but in the medtech department of an insurance company, there are different departments in an insurance company, it's more difficult due to the fact that if you once know a person, the next year he is gone. So the people in an insurance company are also more or less disposables. They are coming and they are going. So that know-how is not very well developed in the medtech field, not in the pharmaceutical field, in the medtech field. So you have to be aware that you always need to be alert by who is where, who do I know, where is he going, who is coming, and who am I able to speak with. That's unfortunately the daily practice today. In the negotiating process with insurance company, a lot of GPs and pharmacists, medical supply shops are in the situation that they have to sign the contract without reading the contract, because there is no choice and there are no real negotiations. It is the insurance company who decides the terms, and the only thing that you can do is sign at where you have to sign. That makes it a very interesting market, because it is challenging if you, as a manufacturer or a distributor from Sweden, and you know that Sweden is highly appreciated in the Netherlands, not just to IKEA or Volvo. Volvo is still Swedish, I don't know. But Swedish products and Swedish companies are very well accepted in the Netherlands. So you have a good chance to do business here. But it is challenging. And that will say that you have to prepare you very well. There's not just come to the market and say, I have a good product, I'm from Sweden, here's my business. That doesn't work. So you need to have persons like Arend, like Bert, like Frans, or whatsoever, who are going to help you by understanding the Dutch market, to find the right relations, to do it in the right way. It is not always straightforward. Sometimes it's going around to have your success, but that you have to understand. Don't go blind in the market, and don't think that I've read the regulations, I do know the laws, and I know what an insurance company is. You need to know more. And you need to have people who are taking your hand and helping you inside the insurance companies or inside the institutions or inside the hospital. As said also in the discussions, I'm jumping from the one to the other. We also said in the discussion that the Netherlands is not a tendering country. We don't like tenders. Municipalities do have to tender, but hospitals don't tender, insurance companies don't tender. Even the government doesn't want to tender, they just buy it. We have seen it in the COVID pandemic, but there's another discussion in the Netherlands, maybe also in other countries, but okay, it was panic. But we don't like tenders. Why? Because a tender is, everybody can see and can read the tender. We prefer here doing business by meeting people, by seeing people, by handshaking, and in relationships. And that's why it is very important to have people who are able to help you with that. That's one of the takeaways also from this meeting. You can have a good business here. There are a lot of opportunities. There are a lot of financial instruments which can help you. In the regions, we have also a lot of organizations, the regional organizations, who are able to help you by starting up a company, by finding the way. They are supporting you. But you need to know the people. It's people business. And if you do understand it, and if you're able to come to the Netherlands and to visit the people, to meet the people, and to discuss what you're willing to do and able to do, then you have a good chance. Then you can be very successful. We see that also there's a tendency buying in Europe, especially in the Netherlands. There is a little bit of reluctancy by buying products from the Far East. If we may mention that, there's also a slight reluctancy when buying from the US due to the fact that there's also a lot of privacy questions in the European Union about these kind of things, etc. But I see a handshake, not a handshake, I see a hand of Masoud Jadidi.
Yes, I have a general question. I don't know if you can answer it or not, but for the cloud solution, is it possible to use the Swedish cloud in Sweden, or we should have a cloud in the Netherlands? What is the regulation?
We have some, it is European regulation, so we don't have Dutch regulation on that, but we have seen a project with a US company with a cloud, of course, in the US. And that hospitals were very hesitating doing business with this US company, because when all the information of patient or doctors is in the cloud in the US, that might be a slight problem if we look to the European rules about privacy, etc. So preferable in Europe. It shouldn't be the Netherlands, it might be also Sweden, but Europe is to be preferred. Or maybe it is forbidden to have it in the US or in Russia or in China or wherever.
Thanks. Thank you.
It's a selling point. If you know, we store it in Sweden and it is well protected. It's a selling point. Questions? Yeah.
Thank you.
Yeah, I can go on with talking about all the things in the Dutch market, but I'm jumping from here to there. So it might be that someone is having some questions about the Dutch market where we go more or less in depth. Otherwise, I make a switch to the next webinar.
I think, yeah, if we don't have any more questions, yeah, should we highlight the next webinar on May 17th? And I would also like to introduce someone by my side, but Ron, would you just like to round up and present the next event?
Yes, if you give my slides, the last two slides. To number 10 and 11, yes.
Ron, can you see the slide?
No. Yeah, I can see the slides, but it's not the right one. So you have to go to number 10 and 11. I see slide number 2 at the moment.
Strange.
I see number 11 now, so yeah, maybe it's lagging for you then, Ron.
It says 10 on my screen.
10 here as well.
Yeah, but I see number 2.
And what about everyone else? I think maybe for us it's the right one.
Number 10, I can see. 10 of
Yeah,
11.
10 of 11, yes.
Oh, you see 10 or 11? Okay, then
10 of 11, yes.
Okay, it's the one with acquiring funding in the end. That's one you see?
Yes.
Okay.
Correct.
Okay. No, I don't see it in my slide. Okay, perfect. What we're going to talk in the next time is that, as Frans already mentioned, there are 2 things that you need to have by means of acquiring a reimbursement. You need to have a code, that is the Dutch Health Authority who is responsible for that, and you need to have a positive decision that your product is reimbursable. That is for the situation that your product is not to be compared with an existing product, because if there is an existing product in the system and you can compare with that product, then you can use that code. And there was already a decision about it is reimbursable, so you don't have to do anything, you just use that code. But there is a problem. When you use the code, you also have to use the price which is related to that code. And it might be that that price is not the price you want to have, because your product is maybe a little bit different and you want to have a higher price, then you can't get it. Or you want to have a lower price, then you still can charge a higher price. So it's depending on the situation. We often see that new products will tend to be a similar product. They said, okay, we are going to use that code, but the price is not enough. Then they have to go in a new procedure to obtain a new code and to obtain, again, a decision about reimbursement. That's what we are going to talk about. And it is the Dutch Healthcare Authority. They are responsible for the coding process. That is also mandatory. You need to have a code, mandatory by law, for everybody in the Dutch market. Codes are, for example, DRG. The Dutch DRG, they say, is a code. A GP does have a code in consultation, a pharmacist does have a code, it is the prescription fee, the physiotherapist does have a code, it is a training, the dentist does have a list of, I think, about 200 codes which they can charge. So that is the activity of the Dutch Healthcare Authority. And there are 3 choices, a free price, free negotiable between the healthcare provider and the insurance company, or a flat price decided by the Dutch Health Authority, or a maximum price also decided by the Dutch Health Authority. And the flat price is in the situation when there is no competition. The Dutch Health Authority looks to the market and sees, hey, a new product is coming, no competition, they want a high price, we decide and we fix the price. That could be the situation that the Dutch Health Authority is deciding about that. Especially in the hospital products, in the hospital service. And if we look to the pharmaceutical products, there are also a lot of rules about pricing. And we also compare pricing in the international level. For medical technology and medical devices, there is no price regime. It is still free pricing. So don't be afraid to ask a certain price, because it's still possible to do so. That's what we are going to talk about in the next meeting. What is the process? What do you have to deliver? To whom do you have to deliver? What do you have to do, etc. And the second part will go about how to obtain a positive decision to have your product reimbursed. That's something to be done by the Dutch Health Board, by the CIN. There are a lot of questions they ask. You can see that on the slide. You have to make a certain dossier with a lot of information about the clinical evidence, about the economical evidence. Of course, you need to have your CE for the medtech. You always have to deliver information about the total cost, the budget impact. You have to give information about quality of life of the patient, also about the burden of disease. So a lot of things has to be delivered to the Dutch Health Board. They are going to decide based on that information, is it reimbursable or not. Then you see already the problem. There are so many products that this institution is not able to do everything. So they have priorities and said, okay, we're not going to do this, but we leave it to the health insurance companies to make a decision, is it reimbursable or not. It might be that an individual health insurance company is doing a process like this, or the organization of health insurance companies. They have an umbrella organization. They're also able to come to these decisions. Now, these processes, what do you do? What do you not have to do? We will talk about in the next meeting. Also, if possible, if there are specific questions or topics that you want to have discussed in the next meeting, please let us know by Anna or by Michaela, so that we can also build it in the next session. And yeah, then you can have a certain understanding about the Dutch market, what you can expect and what you can do. And maybe after this meeting, you know some people like us or the other speakers who can help you in the Dutch market. And let's see what's going to happen. Michaela, up to you.
Thank you very much. I'm very, very much looking forward to actually making a real visit to the Netherlands. The pandemic has stopped everyone from doing the normal business travels. And after listening to this, I'm sure we're in more need than ever of these kind of contacts that you can provide and the knowledge and know-how, because it's very valuable. With me here today, I also have Björn Usching, who just recently joined the Dutch Embassy here in Stockholm. And I thought that maybe we could just take the opportunity to have him present what he's doing at the embassy, since it's really relevant for the life science sector, just to squeeze into the program as well. So I'll hand over to Björn.
Hello, so my name is Björn Usching. I have since a month ago, roughly, started on a position at the Dutch Embassy here in Stockholm. It's a 2-year project where I'm supposed to focus on the life sciences and the interaction between the Swedish and the Dutch life science sectors to increase the exchange between the two. So one of the, I must say that I'm in the midst of defining projects that will be relevant for this. But one thing that I've seen is that many Swedish companies, especially within digital health, they see that the Netherlands is a good choice for a first market. And for you who are in the Netherlands, correct me if I'm wrong, I actually heard that a number of Dutch companies, they see Sweden as the first foreign market. And I'm on the board of a small medtech company, and we want to start actually with both Sweden and the Netherlands as a first market. And I want to try to see if this is a really good idea to make a common platform for small digital startups within healthcare to actually use both the Swedish and the Dutch market as a starting market. And then it needs to start much earlier than just sales. So I want to include also clinical trials, appointment of or looking up key opinion leaders and consultants within both regulatory and market access. So this is in the very beginning. It's not clear in the edges yet, still a bit fuzzy, but I'd like to hear your opinion on this project.
And sort of to clarify also where Ron and all of our nice presenters could loop in, so a unique platform for it.
Yes, it's I must say that I have the money from for my position. It's not connected to any organization more than the embassy. So it's somewhat of a standalone project that anybody could connect with, if you like.
With all this said, do we have any comments from the audience?
Now, now I am audience, so it's also a good thing. You said that also companies from the Netherlands would like to go to Sweden. Yes, we see often that Dutch companies are willing to go to Sweden because it is a rather good market with good pricing, steady people, etc. And it's also reliable. Also, the processes, as we know, are in Sweden not so difficult to enter the market. So that's correct. The Dutch companies are also willing to go to Sweden. If you look to the international market access, we always see, of course, that US companies or companies from other countries outside of Europe, that they are going for the big five. Of course, Germany, France, UK, Italy, and Spain. And then maybe the Netherlands, or maybe the Nordics, or maybe Austria, and we're always on the second hand or second place or whatsoever. So initiatives to have a stronger position and to make it more interesting for companies to start in the Netherlands or Sweden or together as a certain platform is very interesting, because it might be that then companies said, okay, if this is in a certain cooperation and when it goes quicker and much better than if we do it separately in the Netherlands and Sweden, but you can do it together, is that a USP? And that might be interesting that the smaller countries, like we see that also the Netherlands is working together with Austria, Ireland and Belgium in buying of expensive medicines, and they're also working together. That working together as countries and make it possible for startup companies to make a quick start when they then can go to other countries, because with this experience is very worthwhile. So I can only support this idea.
Great. And from the rest of the audience, do we have any suggestions on things that you want us to bring up? Because the second event is meant to take place on the 17th of May. Same time as today, between 1 and 3. We actually realized that it is Vitalis at the same time, which is a large event here in Sweden. So could we maybe get people to raise their hand if it's if the date, if you think that we should try to find another date due to this, because it was just brought to our attention. We forgot about the Vitalis. So if you find it, if you find it difficult to attend due to Vitalis, raise your hand in the chat. Yeah. So let's see. So there will be a third event as well, and we're sort of summarizing questions from you to understand which parts you're still in need to know more about. So feel free to email us at Swecare or medtech for health to sort of ask your questions. so we make sure that the events will be relevant for you. Yeah, do we have any questions from the audience? Just general questions. Per, do you have a question, or Per Trossmark? Maybe, yeah, maybe the hand was raised just in on the topic of Vitalis. But with that said, we would just like to thank everyone for taking part in today's seminar, the first in its first out of 3. We are hoping to do a physical delegation to the Netherlands in the fall, but we will stay in close contact with those of you who are who've been taking part in the events in regards to this. And also we encourage that you have parallel discussions with the speakers here when you have your questions, direct questions. So Henrik or Anna, do we have any finalizing words from you? No?
No, just thank you. A lot of useful information, I believe, and more detailed, but also the general ones, like we're not a country that likes tenders. I don't think anyone does, but yeah.
No.
Oh, it's been very interesting and very, very valuable, and I look forward to the next seminar.
Thank you very much. Thanks a lot.
And to see you all guys again.
Yep. All right. Thank you very much. Have a nice afternoon, everyone.
Thank you.
Thank you.
Bye-bye.
Bye.
Thank you. Bye-bye.